Good afternoon to you all from Hogrefe UK. My name is Jamie, and with me today is Professor Roger Baker, the lead author of the Emotional Processing Scale, who will be guiding this webinar today. This is a recording of a previously held live webinar. The content of the presentation will last roughly 40 minutes. A little bit about our presenter today. Roger Baker is a practicing clinical psychologist and professor of clinical psychology at Bournemouth University. He has worked in dual roles as researcher and clinical psychologist at Leeds, Aberdeen, and Bournemouth universities, and in NHS mental health and NHS hospital trusts, specializing in emotions, the treatment of anxiety disorders, mind-body approaches to health, and in setting up a research advisory service for health service staff. His previous experience in psychometrics includes the development of Rehab, the Rehabilitation Evaluation Hall and Baker. His 3 popular psychology books relate to emotional processing in panic, in post-traumatic stress, and in psychotherapy. And I will now pass you over to Roger, who will introduce you to the emotional processing scale.
Hello, I'm going to discuss the emotional processing scale. My name is Roger Baker. I was the lead author of the scale, but of course it wasn't just me, because I'm part of a much bigger team. We started developing this in the millennium year actually, and it took us 15 years to develop it, and it was published last year. The core team, myself and Professor Peter Thomas, who's Professor in Healthcare Statistics and Epidemiology at Bournemouth, and Dr. Sarah Thomas with the Psychology and Health Psychology background, who's Senior Research Fellow in the unit, and many, many other psychologists who've helped us on the way, and doctors and other professions too. So just to give you an idea of what I'll cover in the webinar today, first of all, to give you an idea where this whole idea came from, where it emerged from, the background ideas, how we built a model of emotional processing on which to construct the scale, how the scale was constructed, the actual form of the scale now, the booklets and manuals, what exactly it measures, and how to use it clinically and in research. And just last week the new digital format was published, so just a word about that too. Now, emotions are ephemeral. They're hard to pin down and define. They're largely subjective. So the question is, when you think about emotions, can you ever develop a way of measuring this elusive phenomenon? And it's not just emotions we're talking about with emotional processing, but we're talking about a change in emotional state from a distressed or aroused state right through to a more settled condition where material has been properly emotionally processed. So that's even harder, if you like. And to make matters worse, we set ourselves quite ambitious aims for the scale. We wanted to have something that could measure emotional processing styles and deficits, something that could predict the role of emotional processing in both physical and psychological disorders. Important to be able to measure change over periods of time, particularly pre and post therapy. Provide a framework for categorization. And in general, a research tool that those investigating emotions could use. And last of all, importantly, a clinical role, of course, in helping therapists to formulate patients' problems. So those were the aims. Now, when I say, can you ever develop a scale, obviously we think you can, and we have done. And this is the scale. There's it's in a package, and there are 3 elements to it: the manual on how to use it, the norms booklet on the backup norms, and the 25 of the scales themselves, the scale booklets. So we do think it is possible to capture something, and we believe that we've got in touch with some crucial dimensions in emotional processing, and I'll try to elaborate that as I go on. Just these are the dimensions that we measure, and I'll talk about this in a little more detail later. Suppression of emotional experience and emotional expression, signs of unprocessed emotion, controllability of emotion, emotional avoidance, of course, very important. There's a lot of research showing the crucial role of that now, and emotional experience, how people experience feelings and the blockages there. And all this, so there's 5 subscales and a total score as well. Just a bit of background now as to how this developed. I was actually in a psychology department in Aberdeen, and the department, we were all fascinated in panic attacks and developing a cognitive therapy for panic attacks at the department, and we did a lot of research in that. This was before Beck's cognitive theory had emerged, so it's kind of, we thought we were leading edge at the time. I saw many patients with panic attacks both in therapy and for research, and ultimately wrote this self-help book for people on understanding panic attacks. This was based on Kelly's construct theory, another cognitive theory, but it's very, very similar to the CBT as practiced today. But one thing I noticed in seeing so many people with panic is, for uneasiness, there was something about the way they described their emotions which seemed unusual, or something about it which made me sit up. For instance, just take control of emotional experience. This lady at the end of therapy said this: that's before therapy, I wanted everything to be perfect. Nearly every day I was wanting to stay on this happy level all the time. I didn't want to appear out of control to anyone else, angry, unhappy. I'm not going to let this bother me. Nothing bothers me exterior. Now, I've come to the regrettable conclusion that ups and downs are normal. This is after therapy, explaining ups and downs are. Well, now, why shouldn't she realize ups and downs are normal? Why does one want to stay at exactly the same level of emotion all the time? And also, it does, not this quote, but other quotes show a lot of suppression of emotional experience. So I thought, being a good psychologist, let's do a controlled study of this. So we chose a panic disorder group of 48 panic patients and 2 control group, the Scottish control group. We were based in Aberdeen here, so that's the Scottish control, and also a London group of controls as well. It was difficult to measure emotions because there weren't many scales around, and again this alerted me to the fact that, well, a scale was needed in this area. But the core total emotional control scale had been used with cancer patients to measure the control of 3 emotions: anger, sadness, and anxiety. So these were the measures of those in the panic group on all 3 emotions. We would expect control of anxiety to be very high, but also it was the same for sadness and anger. Highly significantly different from the Aberdeen group, and even more so the London control group. Now the figures, the statistical figures that came through from this were it was a 1,000,000 to 1 probability against this being a chance finding. So there was p equals 0.00001. And I hadn't seen this before. Usually we're satisfied with p's 0.01. So we seem to be talking about something a pretty big effect here. So it wasn't just the control of all these emotions that was different, but I had made measures of other things, such as one's understanding of emotions, one's ability to label emotions, and again there were significant differences there. So this suggested to me that I was on the right track. This was an important phenomenon, and someday we would produce a scale to measure it, but that was later. At first I thought that this was just related to panic attacks. But then it became fairly clear that other anxiety conditions, post-traumatic stress disorder, generalized anxiety disorder, OCD, etc., it seemed to apply to them too. And then, as I went on, to depressed patients, and as more and more people used our early versions of the scale, we realized it applied to anorexia, to alcoholism, also to medical issues like IBS, pain, fatigue, and cancer and asthma. And the more other people used it, the more we realized that this seemed to cross the board. That's why I've used the term pan-diagnostic. It seems to apply to all the psychological disorders. And possibly, it's coming into contact with a deep area that maybe underlies so much psychopathology, maybe a common underlying emotional area. So the scale can be used with people with psychological problems and disorders, people with psychogenic conditions, people with medical conditions, and of course, very importantly, healthy, normal people, because we all have to process difficult hassles and events and traumas in our lives. So this applies across the board. Now, Jack Rachman was the first to define emotional processing in 1980. He called this a process whereby emotional disturbances are absorbed and decline to the extent that other experiences and behavior can proceed without disruption. We have trauma, difficulties, which cause various emotional effects in us, but when processed, these it becomes more calm, and we can continue life successfully. But he did point out that most people successfully process the overwhelming majority of the disturbing events that occur in their lives. But with such, as I say, an ephemeral phenomenon, this is just to suggest it's a sort of, the idea behind it is a sort of natural healing process that we go through, as long as it's not hindered, that even quite disturbing traumas and events can be processed, and a measure of healing can be found. As I was saying, that emotions are ephemeral, it's true, and in order really to get over this concept, Rachman and Foer, who's the other leading exponent in emotional processing, had to use metaphors in that description of emotional processing. So Rachman referred to the absorption of disturbance, transformation of stimulation, adapting to emotional disturbances, and Foer talked about new information has to be integrated into the evoked information structure, or she referred to it also as the essence of recovery. And emotional processing occurs only when it is encoded and incorporated into existing knowledge. So many different metaphors in that. Foer was more specific in pinpointing a mechanism by which emotional processing might work, but also she allied emotional processing quite closely with behavioral exposure. In constructing a scale, of course, you've got to develop a model as a sort of skeleton to start with, to know what you're measuring and to make sense of that. So we realized that this was an important first step. So that was our first step. And the model, which is described elsewhere, so I'll just mention some of the key elements in it, involved quite a lot of the important aspects from psychological theory. We relied on many different approaches, for instance, emotion theory, cognitive therapy, behavior therapy, experiential theory, psychodynamic theory, health and immunology, and neuropsychology. So here what we call the input event also is called stressor by Hans Sale, who defined the term stress or trauma. The memory of an input is crucially important as well, because okay, you might experience a trauma once, but of course it's replayed in memory many times, and the emotional element is stored in memory. Cognitive appraisal, central concept in psychology, cognitive appraisal, that the input is appraised in a certain way, but also you appraise your emotional experience. It occurs all across the board. Jeffrey Young's idea of schemas, or emotion schemas, really important ways of perceiving laid down even before words are developed in how we see life, shape the way events are viewed. We all have families and cultures which have certain implicit emotion rules. We're probably not aware of our own rules. It's only when you go to a different culture that behaves entirely differently that you sort of become aware of your own rules. And every family is a bit different. Every individual is a bit different. This is why we talk about styles of emotional processing. And every culture is different. So there are these, that's incorporated into the model. Of course, emotional expression is one thing, but also the experience of emotion. We have incorporated that into the center of the model as being important, experiential things, emotional expression, and one's understanding of what's going on emotionally. And last of all, the regulation, which starts from childhood onward. Jeffrey Young's work is important here. So all those elements were integrated into the model from which we constructed the items. Okay, how was the scale constructed? So the initial item selection, that went on over a long period of time before we ever started this scale construction properly, gathering information from many sources, from clinical cases, the model itself, case histories from various sources, written and verbal, and the literature on emotions as well. And also, perhaps not mentioned here, is personal experiences as well. That all goes into it. So 30 draft items were developed. And these were whittled down with the help of colleagues from different professions to 152 to our starting scale at 101 items. So that first version of 101 items was given to 150 people altogether, healthy people, people sitting in a doctor's waiting room, and some mental health patients. A lot of analysis at this stage of what were good items, what were poor, which items best distinguish the groups, what the factor analysis seemed to be showing, many, many different types of analysis, which Peter Thomas, the statistician, led on this one. And that led to version 2 with less questions, given to a larger sample of people, including some cancer patients, back pain patients, and older people, of course students. More analysis of various types here to whittle it down, to improve it. We wanted good items which distinguish well, which didn't have many zeros in, which had ratings across the board. This led to version 3. A few more items added because we were then pretty much aware of the major factors involved, and so we're trying to beef up some of the factors with some more items of that sort. Given to 690 people, again a lot more analysis until the final version emerged with just 25 questions covering 5 different subscales. This is how the questionnaires rated. These are 3 items. It's rated on the basis of events in the previous week, and this is a rating which incorporates visual analog. So you put your rating of agreement somewhere along the line, also numerical, and also verbal, and the dots here indicate that there's a continuum up to from completely disagree to completely agree. This is a format originally developed by Isaac Marks that we used in rehab successfully, and it different raters rating different ways. So this covers this kind of can appeal to everybody in their rating. So they have to rate how much they agree that this applied to them in the last week. I smothered my feelings. So the person's pretty much agreeing, yes, that's what happened last week. I did smother my feelings. Unwanted feelings kept intruding. No, not really, they're saying here. And when upset or angry, it was difficult to control what I said. That's a sort of kind of in-between score there. In the published version, it looks slightly different, but the idea is the same. Now we've produced 4 journal articles on this. The initial one was describing the emotional processing and panic work that I described earlier. Then the early development of the scale and the model behind it. This one, Journal of Psychosomatic Research, was finalizing the scale, the 25-item version that I mentioned. And last of all, a scale looking at the validity of the emotional processing scale in measuring change during therapy, which was CBT. And there's a book, this is a paperback explaining emotional processing for a popular readership, I think, with many case histories of how it applies in different conditions. Now, one thing that surprised us, we gave papers at various conferences and that, is the number of people over the 15-year period of its development who contacted us who wanted to use the scale in their research. So there are many collaborations throughout the world, and it's been translated into 13 languages. Not published in those languages, but translated and used in research. We were continually surprised the different ways people use it for, and the different patient groups. That's how we kind of realized this has a very broad application, and it's spread from the idea it's just panic to lots of other things. For instance, there have been studies looking at differences between groups. For instance, diagnostic comparisons. Banerjee compared pain patients of different presentation, chronic gastrointestinal pain with chronic neck pain, etc. in emotional processing. Comparison between symptomatic and improved patients. So this example is patients with depression. And it can be used, of course, in cultural comparisons. And this is a study by Sant'Anastaso comparing English, Italian, Japanese people on emotional processing. And another study comparing Polish and English students. And also there were some studies which compared two different events. So healthy individuals had had a stroke, those who hadn't, or healthy controls and those who were the adult survivors of childhood sexual abuse. So that's looking at differences. It's been used in therapy. The most common one is measuring the effectiveness of therapy from pre, mid, post and follow-up. So that's measuring a pain management program. Picard did research in this, and another one is looking at the changes that occur during therapy, and this was a psychodynamic guided self-help internet program that they were examining. Correlational research, maybe investigating the relationship between emotional processing and other variables. This looked at post-traumatic stress and emotional processing, pain catastrophizing and altered self-capacity. Sometimes emotional processing is regarded as a mediator between two variables. For instance, this study which assessed the link between insecure attachment strategies and psychosomatic disorders, looking at the potential mediating role of emotional processing and cognitive processing. Predictive research is rarer in psychology. This is that you're capturing a disorder before it develops and seeing if a factor can predict its development. And so there's a very large study carried out by Carol Wilkins at Bournemouth University of nearly 1,000 women who are pregnant, where she looked at their emotional processing at 13 weeks and at later on in pregnancy to see whether it predicted the development of postnatal depression. It was a very good predictor. It predicted it almost as well as the Edinburgh Postnatal Depression Scale, which is a measure of depression. Psychometric research of various sorts, translation studies, other reliability and validity studies. This one looked at the meaning of items. This tested the English phraseology, so there were changes for the states. And of course, important areas, emotional processing in healthy individuals, and you've got to have students when you're doing research. That all psychological research seems to do that. So this is a study with students, but also a community study by Romanov Bucks looking at an aging sample and how emotional processing related to age and development. Now the scale was published last year, July last year, by Hogrefe, a European psychometric test publishing company, and this is the headquarters in Oxford, The main headquarters is in Germany, and there are centers throughout Europe. There are three parts to it: the booklets themselves, the manual on how to use the scale and make sense of it, and the norms to back up everything else. So let's look at these different elements. Okay, the manual itself, I wanted to try to make it as easy as possible for people to use it and understand it, because there are several different uses, so it can be complicated. So we reckon that there are about 15 different possible uses for the scale, and we chose examples of case histories depending on the different aims, and have taken people through the different case histories and which tables you use and how you make sense of this and what you do. So it's quite a, I hope, a clear guide to what to do. For instance, in identifying targets for therapeutic intervention, we use the example of Stephen, a soldier with post-traumatic stress disorder. If you want to measure changes in a group, we've used a case study of a new therapy for medically unexplained symptoms in hospital. Personal development of somebody who's otherwise quite healthy, we use the example of a successful GP, but he felt there was something missing in his treatment of patients and his home life. Assessing risk, so to do this we looked at the vulnerability of paramedics in an NHS ambulance trust. Was the scale able to predict those most vulnerable, and was it able to guide in what to do about it? Ability to cope with medical procedures, we looked at a 25-year-old student with Crohn's disease facing surgery, major surgery, and how he might be able to cope and what his strengths and weaknesses were. Using the scale for cut-off scores, and this was a study looking at memory and emotional processing students, using people who had poor and good emotional processing skills to see if there was a difference in memory. So that's the manual. It goes through in a lot of detail, describes the background and also what to do essentially. The norms booklet, separate booklet, with our so many collaborators, we wrote to them all and said we're producing the scale, we want as valuable a set of norms as possible, would you provide us with your data? And 27 of the collaborators did provide their data, so we have quite a full background data set. So these are the different patients who were rated in the area of mental health. There's some data from childhood experiences and teenagers rating their emotional processing. There are pain groups. There are various healthy international groups. There's a healthy community group in the UK and pregnant women. So in total there are just about 7,000 people who are assessed. So there are different norms presented for different groups. So it's quite good to be able to rely back on different norms depending on the person you're investigating in front of you. Now the scoring booklet itself, what does it measure? We tried in the initial item selection to have as many positively worded items as negatively worded items to make this as much about measuring super emotional processing versus poor emotional processing, but the much more reliable data came from the more negative tin. So I think it does measure more problematic emotional styles than super extra emotional styles, those who are superior. We chose these on the basis of the various analyses and the different studies we've done. The 5 factors we chose were based on the model, the clinical utility, the scale, and several factor analysis scores. Now our statistician reckons that factor analysis is one of the dark arts, revealing secret patterns in the data by some statistical wizardry. And in a way this is true. It's very appealing because it does seem to show you patterns you can't detect by the eye. But the hidden meanings are somewhat dependent on what you put in. Those items you include in the analysis are what you don't. It also depends on the factor analysis method you use, the type of rotation, the criteria for extraction, the number of factors you choose. So it can vary a lot. There's not a fixed answer. There's no one true answer. So although it seems to promise you, the ultimate truth, it's not quite like that. So in choosing our subscales, we didn't only rely on factor analysis. Yes, we did take notice of this, but the clinical usefulness was pretty important. We realized it must be a short scale. You can't give patients tremendously long numbers of items. We didn't want more than about 5 subscales because it's conceptually difficult to interpret things with so many factors. We wanted every item to have a good spread of scores and to be able to distinguish different groups, diagnostic and healthy groups, for instance, very well. So there were many criteria in choosing the ultimate items and the factors. So the 5 factors, if I just briefly go over those, one is called emotional experience. Now, there are various mostly derogatory terms towards this. This is often referred to as poor emotional intelligence or emotionally unaware. Alexithymia is a term that's been used with this. Mild Asperger's, a somatizer, that the person picks on the physical aspects rather than the emotional. And perhaps one of the most unfortunate is emotionally illiterate, which is a derogatory term. But this factor seems to be measuring the person's understanding of their own emotional life and how vibrant their emotional life is. So here's a couple of items from it. My emotions felt blunt or dull. I was unable to figure out if I felt ill or emotional. The next factor is quite closely allied to Rachman's concept of emotional processing, the signs of unprocessed emotion. For instance, unwanted feelings kept intruding, the intrusiveness of emotions and memories of emotional situations that just won't go away, keep you awake. I repeatedly experience the same emotions, those sort of items. The third factor, perhaps we're all familiar with this, avoidance, yes. As I mentioned, emotional avoidance has become seen as quite central in many factors, borderline personality disorder, for instance. The degree to which people will avoid experience, not just negative feelings, sometimes positive feelings, not experience, wanting any experience. For instance, I tried hard to avoid things that might upset me. I could not tolerate unpleasant feelings. Next factor, perhaps you think of first with emotional processing, is suppression of emotional experience and suppression of the expression of emotions. I bottled up my emotions. I kept quiet about my feelings. One factor that we didn't foresee in the original model but kept on emerging very strongly in factor analysis was controllability of emotions. How much the person feels they have control over their emotional life. For instance, when upset or angry, it was difficult to control what I said. I reacted too much to what people said or did. So those are the 5 factors, and together they make a total emotional processing score. So there's 6 measures that come out of the scale. I'd like to turn now to just how to use this scale clinically. As I said, it's been used in a lot of different research studies, but now the clinical use. If we look here, it makes quite clear in the instructions at the front that it's based on the last week. So it's asking the person to fix the last week firmly in their mind, asking them to spend a few minutes thinking about what they were doing last week, the events of last week, where you were, what you were doing, check on the diary and that. So a lot of it is focused on that, and the wording in the scale keeps reminding people of the 1 week period. We felt it quite important to have this period of rating set at just 1 week to avoid halo judgments, because if you ask people about their control and suppression of emotions. They might evaluate themselves rather too kindly, but if you pin it down to actual events that happened, I think you're more likely to get a reliable and valid score. So that was the idea behind this 1 week basis. And so they make their basis on that 1 week. The scale actually starts off here with 2 boxes which are ask people to write in here what was your most strongest positive emotion last week. The person writes that in, and what was the strongest negative or unpleasant emotion you felt last week, and they write that in as well. This is interesting data, but the key idea of this is to get them focused on that last week. So it's firmly in their mind. It is based on a week. There's a couple of examples we start off with here where it gives an example of it. I kept my feelings to myself, and the score and what that score means. And here's another item. So the person has seen how to do it. Now they go on to the last week and rate the 25 items. Then you come to the end of the items. There's another box saying, is there anything else emotionally that is important that we've missed out? And then it's given to the test administrator, psychologist, or the person doing the scoring. And there's a back piece which is exclude, and you pull this back to reveal the profile chart and scoring sheet underneath. On the scoring sheet on the right, the raw scores are taken from the scale, which is to the left, all the scores, and put into the boxes. It's very quick to do this, and then the test administrator is asked to tot up the raw subscale scores and calculate a mean for each item, and of course the total score as well. That's then taken over to the profile chart, where the person's scores are plotted on a percentile scale here, and this is a percentile based on about 2,000 healthy UK adults. So the middle part here is just average. It's between the 25th and the 75th percentile. That's the bulk of people would fall within this area. When you move beyond the 75th percentile, it's getting fairly high. High means problematic scores. The reverse here for less problematic scores are below the 25th percentile. Up to the 90th percentile, so this is the most problematic 10% of the population here, and the most problematic 5% of the population. So you've got quite a nice visual presentation of their emotional processing style, their strengths and weaknesses here. So for this particular person here, it's all average. This one does dip. This is their experience and their understanding of emotions. This does just dip into the high average area, but not extremely so. So this is helpful for the therapist in planning out therapy and understanding the strengths and weaknesses of the person. It can also be used outside the therapy situation for a person to just understand their own emotions a bit better. But also, and I've found this consistently, to show this to patients maybe after the first or second session and go through it with them, they find this very helpful indeed, and it of course focuses on emotions as a part of therapy. I think this is one thing. I mean, we've had behavior therapy, cognitive behavior therapy, and they're very well served with therapeutic techniques and assessment scales, but it's the emotions which is the Cinderella here. There's not so much in the terms of emotional techniques and emotional assessments that can be used in therapy, and the hope is that this does fill a gap, fill a need there. In describing it to patients or people, just all the 25 items are briefly down at the bottom, and any ones that have very high scores are ticked off or marked off so that you can describe what this means. For instance, with the poor experience score there, my emotions felt blunt or dull. There was a big blank in my emotions, and I had strong feelings, but I'm not sure if they were emotions. These were the 3 highly significant items, and that allows you then to talk easily to the person about this. So that's the whole scale out the end of the score, the end of the sheet itself, the profile chart and the score sheet. Now, in therapy, seeing people, I use different techniques, cognitive, behavioral, and more emotional processing therapy. And so it's a combination of different approaches depending on the person. But I've found this extremely useful in therapy. Now, I know I'm the author, I'm saying that, but before this was actually printed in the printed up version of that, it was in a different format, and we didn't have the percentile charts and didn't actually use it so much in therapy. Now there's this version that's easily seen. You know, you can look at this profile chart and make instant sense of it, and patients can as well. I'm giving it to nearly everybody I see now, and I'm finding it very helpful, as are other psychologists. So just to give you a few case examples here, just a couple of case examples just to give you a flavor of this. This was a lady who was referred to me. It's a doctor who had been mugged on 2 occasions, and after that had developed serious post-traumatic stress disorder, which meant she could no longer practice as a doctor. She came for therapy, and this, on the first session, there's our pre-therapy scores, and you could see that nearly all our scores are in the very high levels. The avoidance of emotional situations was sky high, as was her suppression of emotions, lots of unprocessed material. Her understanding of her emotions wasn't too bad, it was still within normal limits, and her feeling of control over emotions was okay. So because she was a doctor, she understood percentile charge. We could go through this, and she was really very surprised at how extreme her emotional reactions were. But this fitted very well with her own experience, because she'd been to a school where she was very upset and cried, and she'd been told, just pretend you're happy and it will be okay. So her family style had been one of pretending you were okay and not mentioning differences, getting on with it. And of course, this fitted okay with a lot of her medical training until she had these overwhelming events. She didn't share what had happened to her with anybody. She pretended she'd slipped and hurt herself when she went into accident and emergency. She didn't share with colleagues, boyfriends, family, and that. This had been her style. So actually, this was picking up something which she mentioned quite a lot in the therapy anyway. So this helped to set the scene for a change in style. She realized that she would have to talk about things more, not suppress them, that it was safe enough to do this. And actually, it was part of the problem that she had suppressed so much. And as we went through a emotional processing therapy, it was very similar to exposure to the memories of the traumas. She understood why it was important to express emotions and talk about them and cry, and she was very motivated to see it through now that she understood more about her emotions. And this is a score later on in therapy showing essentially normal or better than average levels of emotional processing. And she described her style to me, and she was talking to her family a lot, her boyfriend, to colleagues, and she'd found that when you actually shared with colleagues, they were sympathetic, and they provided extra facilities to make it easier for her and help in her rehabilitation, and so it actually was a far more successful strategy to be sharing emotionally. Here's another woman who came for therapy with severe panics that had lasted many years, which meant that she couldn't attend university, couldn't sit in lectures because of panic, and panics with driving, heights, and various other situations too. But she was having recurrent panic attacks, couldn't remain in any situation that was trapped for very long. Again, very high scores across the board, except for avoidance. This is kind of interesting, because in therapy, usually this is one of the things you would go for with panic. You would try to, the person's been avoiding, and this has been part of the problem, you try to get them to face things more. But this didn't seem to be an issue, which was interesting and led to a type of therapy which was slightly different to normal. But the unprocessed, the high unprocessed material was related to perhaps some of the original causes, very, very difficult relationship with her father, who was abusive to her, and which meant that it caused so many different problems in relationships and trust and other things. And ultimately we talked about this a lot, as well as dealing with the panic symptoms. There's just a couple of examples, but it seems to have quite broad uses to different areas. Just to go on now to the new digital format which has come out. So this is where the patient can rate on a laptop or screen. And as you see, it's similar to before. There's the visual analog, there's the verbal statements, and there's the numbers that the person rates themselves on last week, and they click on it once and click on it a second time to move on to the next item, then next. Doing it this way, there's a lot of background data in a report that can be produced. So all the norms are built in this. So when you look at the person's scores, you can choose the normative group against which this person is compared. So here we've got the addiction group, so it's somebody with addiction, and we're looking at the total addiction group. We could look at gender differences. We could have looked at female people with addictions. And this can be looked at in many different ways. For instance, it could be, this is T-scores here, but it could have been Z-scores, percentiles, Stein-Iron, Stens. So you can choose your type of measure. You can choose whether you want it as a profile, a table, or whether you want the specific individual items displayed, or you want to look at the distributions of particular items. There's many different ways that you can choose to have this displayed, which is quite neat. Here's the display sheet showing you the patient, how many times the test has been given. This is a hypothetical example. So this is the original score. Here we presented it, the scale was given in pre-therapy, mid-therapy, and post. And we can see a change throughout. So we're able to plot this on a scale, which is quite nice to do. So that's I saw a demonstration of this last week, so it's quite impressive. So that's the graphed version of this. So thank you very much for listening today. I'm hoping that's given me a flavour of what it's all about, where it came from, what it's able to do. There's more information available from different websites. There's this website on emotional processing looks more at the theory. There's another website looking at the scale itself, its development, another website looking at emotional processing therapy, and the Hogrefe website on emotional processing, which has a lot of information. So thank you very much for listening today.
Wonderful. Thank you so much, Roger, for that thorough, very engaging presentation. Just to reiterate, please do contact us using the details on your screen. You see the URL there for hogrefe.co.uk. You can find our email address and our phone number on that website. We would love to hear from you. We would very much love to discuss your use of the EPS. And we can talk to you about the different formats that it's available in, the digital or the paper and pencil. We can share sample reports, and we can also set you up to try the EPS online for yourself. These are all options that we would love to share, so please do get in contact. And my sincere thanks once again to Professor Roger Baker for joining us today, and thank you very much for listening.